part of the seminar series for the McMaster Institute for Health Equity. We will begin by giving honor and thanks to the Haudenosaunee and Anishinaabe nations as the traditional inhabitants of the lands where McMaster stands. To say that is to acknowledge a debt to those who were here before us and to recognize our responsibility as guests to respect and honor the intimate relationship Indigenous people have with this land. We are so very pleased to have Dr. Ameil Joseph as our invited speaker today. Dr. Joseph is an associate professor in the School of Social Work at McMaster University. He currently holds the Professorship in Equity, Identity, and Transformation from the Faculty of Social Sciences at McMaster University and is the academic director of Community Engaged Research and Relationship for the Office of Community Engagement. Dr. Joseph research draws on perspectives of critical forensic mental health, post-colonial theory, critical race theory, and critical disability studies to analyze the historic production of ideas about our understanding of sexuality, race, ability, and mental illness as they diverge, interdepend, and perform within policy, law, and practice. The topic of Dr. Joseph's presentation today is extremely timely and speaks to the overwhelming impacts of COVID-19 on Black and other racialized communities in Hamilton. As many jurisdictions, including ours, have or are preparing to rescind public health measures that were put in place to control the COVID-19 pandemic, it is important to hear about the communities that have been disproportionately burdened by the pandemic, especially within the context of Canada, where wide-spanning protests and occupations are taking place by the so-called freedom convoys, who have organized around the cause of eliminating vaccine mandates and other public health measures, but whose organizers, rhetoric, financing, and support has been revealed to be entrenched in far-right, white supremacist networks and ideology. Thank you once again, then, Dr. Joseph, for sharing your important and timely research with us today. I'll now hand it over to you.
Thanks, Marissa. And thanks everyone for joining. I'm just going to share my screen here. I'll just do a little check here, make sure everyone can see my stuff.
Yep, looks good.
Great. So yeah, good afternoon, everyone. I know there's a lot going on in the world right now. And, hopefully by the end of this talk, you'll see what I see and share some of my feelings of hope. I think, people have been watching and appreciating, sometimes in horror, the exacerbation of bigotry and hatred that many have tied to this particular historical moment. And we've seen images and videos of hate groups organizing and hate incidents occurring at frightening rates, much as this is talked about as racism at a kind of individual level. And at the same time, these incidents have helped many appreciate the scope and impact of anti-Black, anti-Indigenous, anti-Muslim, anti-Asian, and anti-Semitic forms of racism. You'll notice there that I often refrain from using terms like Islamophobia or xenophobia or xenophobia, as they sometimes direct or shape our attentions back to the intents of individuals rather than the ways ideas are shaped and supported by policy, by history, by systems and structures. Those words also imply a psychological illness or pathology as an anomaly rather than have us engage in solidarity around issues of complicity and complexity. Canada has its own very unique histories of race and racism, of racialization and colonialism that we often do not acknowledge in the dominant ways we talk about history. We rarely talked about things like residential schools in Canada, or how South African politicians came to Canada in the 1940s to learn from our racism in the Indian Act, how to use status cards and the reserve system in apartheid in South Africa. It would take several weeks for me to talk about things like Chinese head taxes, Japanese internment, the turned away ships of South Asian and and Jewish people, of chattel slavery and Black settlements erased in these lands, and how those histories frame civil and social relations in policy, practice, and law in Canada today, including in health systems and policy and research. In my research, I've traced some of the historical pathways that discriminatory ideas, in ways that discriminatory ideas have shaped mental health and criminal justice and immigration policy, practice, and law. And these racist ideas took hold many years ago. I think our job is to think about how those ideas have been divorced from their original projects, yet continue to operate with similar outcomes today. How they operate within professions and disciplines, practices, policy, and law, in how we think about capacities and capabilities and excellence and threat and burden and risk in racialized ways. So this is not about you having to identify as a bigot or feel guilty. That reaction all too often comes from a place of privilege and undermines our work to listen to those who experience racism and act in accountable ways to respond to our complicities. These matters are, of course, very local as well. Hamilton is ranked, in the top 3 in terms of per capita police reported hate crimes for several years. We've had significant hate-based atrocities occur in Hamilton, including arson attacks on Hindu and Muslim places of worship, racist symbols found on synagogues, and ongoing issues with racial profiling in policing. These kinds of things shape our context broadly, and even how we should talk about disparities, injustice, inequities, and racism in healthcare. And all of these local contexts have historical roots. The KKK were well established in this area. The histories of Black settlements and slave trading in Hamilton are often omitted in the tellings of histories of Hamilton as well. I often tell the story of Hat Street in Dundas. This book in the center tells the story of Sophia Pooley, who was purchased along with their sister by Samuel Hatt, actually from the Indigenous leader Joseph Brant, both of whose names line our streets or towns or institutions today, often without recognizing the racism behind these stories and built all around us, really. I think when I talk about matters of racism and injustice, I need to tell you a little bit about me. One thing about me is I'm a descendant of indentured laborers brought to work in Guyana via colonial rule. On the left, this is my grandfather's birth certificate. On it is a reference to my great-grandmother, just a misspelled first name. Her origin is identified as a boat, foil, in the year 1889. The vessel she was carried on as a 3-month-old infant, a vessel owned by a colonial contractor carrying indentured laborers to Guyana to toil in sugarcane fields. The only other information is a registration number. They're Cal 40711, registration number. On the right is my great-grandmother's immigration pass, document that outlines her caste in a pejorative. Chamar is the word, a word to describe us, a word to describe Dalit or untouchables. She was someone made into a number and an insult, divorced from land and place. I think about this often, how the trajectories of erasure and dehumanization shape us, and how understandings of identity can and should be understood beyond add or subtract calculations of oppression and privilege that oversimplify how we appreciate the impacts of history. I come from a caste of people who intergenerationally have been treated as outcasts It shapes how I think about numbers, how I think about documents and data, and definitely how I come to this work. Everyone has their story, and much of this complexity is too often unacknowledged. I raise these contexts because I feel like they are not named enough in how we talk about contemporary inequities. These contexts permeate our systems and services and programs and disciplines. We've seen, quite a few reports that share racial disproportionalities as just that, often without an embedded analysis that even surfaces the problem of the racial histories of how blame is assigned and where it lands. The portrayals of types of people as threat or burden, infused with racist ideas of hereditary, cultural, or aptitudinal lack. We saw quite a few examples of this in the ways racial disparities were depicted in relation to COVID-19 infection rates. I think, broadly, there has been for several years now an appreciation that racism in healthcare in Canada is a pervasive issue. It is a topic that has found its way into public media and government. And this is definitely a time when we should be taking more action than ever to address it. In Hamilton, in October of 2020, we were seeing that some 50% of COVID-19 infections were among racialized populations. And there were calls for more collection of race-based and socio-demographic data collection to get a better sense of disparities. This was coming from community members as well as experts. And it continues actually in a number of ways. In May of 2020, a group of doctors and professors and community leaders with experience and interest in health equity work wrote to Hamilton Public Health. We recommended that any collection and analysis of race-based data include the processes and methods of collection that these processes and methods of collection be developed collaboratively with local leaders and experts who live and do anti-racism work and research and analysis. We also recommended the establishment of a community advisory committee to structure this into the work to support a responsive, engaged, inclusive, and accountable approach that would improve the quality of analysis. Not only that, but also improve how it might be more impactful on care in Hamilton. And the reasons for this were shared, like I said, with Hamilton Public Health, including the histories of collecting data on inequities without it resulting in change or significant changes to how we think about resource distribution and programming our services. And these are not new conversations. Many have written about these problematics that rely on the collection of data on race to convey action where old social relations, inequities, and injustices are not only maintained, but in fact solidified. Professor Ronaldo Walcott wrote recently that there are indeed some truths about calls for race-based data, but there are many half-truths too. Evidence is important, and few would dismiss evidence as necessary. However, race-based data can quite frankly slow down reform. And in that context, doing the research when a problem is already identified and solutions known means that the collection of race-based data does not actually add much to policymaking. In fact, in some cases, it can do more harm than good. Race-based data collection, as currently articulated, is a response to a set of political concerns masquerading as if it is the answer. Lana James reminded us that personal information, including health data, must be protected, whether it is identifiable, de-identified, or anonymized, that laws, regulation, policies, and substantive enforceable penalties are the minimum preconditions that must be in place before more race-based data is collected and circulated. I myself wrote in a magazine article in Canadian Dimension that demands for equity data are always at risk of being reduced to statistics connected to ideas about impartiality or objectivity about race, which undermine our appreciations of race, racism, and racialization as socially, historically, and politically constituted. There's also the risk of limiting the understanding of lived experience as mere points of data, perpetuating the risks of being used for quotas or tokenism, or to advance racist scientific ideas that falsely equate race with genetic or biological variation. That group that wrote the letter broadened, had meetings with Hamilton Public Health, which were great, and even developed the terms of reference for the group. We did this on our own time, evenings and weekends for nothing. We applied for a seed grant, which we won from the McMaster Institute for Health Equity to help launch our research work. We made clear that we believe in the need for people to be involved in how they are identified, how they are described and analyzed, to allow for transparent data collection and analysis. And that we believe that community feedback, insight, and analyses need to be empowered with the authorities to effect change. We raised issues of the categories being used, the issues of data ownership and access, control, and possession. We submitted it in July and didn't really get a response. Then we heard about a report being released on demographic data in October. So we decided that these issues are too important to avert our gaze, and that a community conversation with people who have thought deeply about these issues was necessary. So we shared our analyses, our perspectives, our rationale, the importance of doing this work properly, and the recommendations for our group was, well, they went unanswered. But I would argue that, this advocacy work is still ongoing and still in progress. And there have been some folks who have been listening and learning as we proceed. In December of 2020, we held an event to explore these very issues, how we might resist the mechanisms and relations that would wield data about race without analyses that highlight what we need to do about racism. In December of 2020, the Hamilton Vaccine Readiness Network began convening. It was a committee of public health, or is a committee of public and community health leaders who worked with public health to think about priorities for vaccination and a lot of these considerations that I've been raising. I was invited by those who knew me through this work and with my community work with the Hamilton Center for Civic Inclusion and the Disability Justice Network of Ontario. And many community leaders took the opportunity on the Vaccine Readiness Network to ask how public health was addressing the disproportionate rates of infection among racialized groups in Hamilton. We suggested a more nuanced approach to data collection that considers the impacts and experience of marginalized populations, the need for dedicated outreach, and to prioritize these highly impacted groups for vaccination. We raised it, discussed it repeatedly, and many of us didn't see action being taken or action being taken fast enough. So we took a bit of our own action. We wrote a letter to the network and to Hamilton Public Health outlining the urgent need to address these disparities with real material action. When we didn't see an adequate response, we took that letter to the public, and over 500 people in Hamilton signed in support of it. And in the letter, we highlighted that we'd been calling for action since December of 2020. It was then April of 2021, and nothing had really changed. This got some media attention, And there was a growing group of Black and other racialized community members and leaders and organizations that serve marginalized communities that rallied in solidarity to take on the work of helping to establish clinics and services to prioritize those being hit the hardest by COVID-19. And there were members of public health connected to the Vaccine Readiness Network that were hearing these conversations and helped us kind of nudge that forward. Narinder Nan, a city councilor, some other city councilors who were supportive of this, all kind of worked in a confluence of ways that helped nudge this stuff forward. And you had Black and racialized health leaders, community organizations, community members, myself included, who began meeting to develop plans to address these needs. And Hamilton Public Health agreed to include us in this prioritization process. And then you had something kind of incredible happen. You had Hamilton Urban Core Community Health Center, Refuge Newcomer Health, Compass Community Health, Centre de Santé Communautaire, the Hamilton Center for Civic Inclusion, the Disability Justice Network Ontario. There were other advocates in the room, ACA, SPRC, who helped advocate for a lot of these changes. But that group of organizations that I described, the community health centers and HCCI and DJNO, agreed to take on the outreach and the bookings and the clinic operations for what became Restoration House. We divided up the work and got to it. And most of these organizations did all of this off the sides of their desks for nothing at the beginning. Later, via more advocacy, some funding was made available to cover the costs of staffing and labor required for the clinic. De Droit, de Desnay, Aboriginal Health Center, the Hamilton Regional Indian Center, and the WASA set up a clinic at the Perkins Center for Indigenous people as well. And then as soon as racist social media trolls heard that there was a clinic prioritizing Black and other racialized people for vaccination, we began to receive torrents of hateful messages. The initiative was targeted on extremist and white supremacist websites. It was a difficult time. I remember McMaster tweeting about the clinic and its work, and they reached out to me because it was getting trolled so hard and with so much vitriol and hate, and decided to pull it. And I had mixed feelings about it. I wanted to explain why these initiatives are necessary, what they're responding to, and how these prioritizations are the kinds of things that are allowed for. We have provisions in the Ontario Human Rights Code that allow for special programming specifically designed to address discrimination. And this was that kind of initiative. Like I said, it was a difficult time. But we also had groups of Black and racialized health and community leaders who took some of this work further and took the calls for structural change to City Hall to recommend a change to the structure of the Hamilton Board of Health so that its membership was comprised of more than city councilors, so that there were built-in perspectives from community and health leaders, including and especially those who work with the most marginalized populations in Hamilton. And so there have been letters and meetings and delegations at City Hall. And I would say this advocacy effort is also one of the arms of this work that's still in progress. In the early days of the clinic, there were ways to book through the City of Hamilton's booking system and phone line, and community agencies themselves were doing bookings and outreach manually. through the populations they serve. And the collective suggested that community-based booking and outreach needed more support. And eventually the work of this prioritization initiative was transferred to primary care, the provincial system. And we received more support for community-based outreach and bookings, and Refuge Community Health helped lead the work going forward. They had their own Verto-based booking system, and we're doing a lot of the advertising for the clinics themselves, and being responsive to needs that were being shared across the community health centers and the community organizations that were helping lead the outreach work. And those kind of conversations were heavy. They were complicated. There was a lot of work involved. Often that isn't widely publicly talked about. The initiative then after transferred to primary care, now led and run by community health centers, community leaders and organizations, developed plans for mobile clinics and numerous locations, disseminated the information through in-person outreach, online and social media in numerous languages, held specialized clinics for people with disabilities, made clear that things like health cards weren't necessary for those who experience barriers to documentation. And thousands of people in Hamilton have been receiving their vaccinations through that work, that initiative. I and others have received emails and messages from individuals and families that shared their gratitude for the clinic, stories about having such a great experience that they had all of their family and extended family go to the clinic. It was something to see. And the work continues through walk-ins now at the Hamilton Public Library, Barton Branch. What also continues, I would say, are the solidarities and relationships that were built here, some of which already existed, but many of which began through collectivity and resistance. They merged through advocacy. They stayed focused on need. This is the kind of story you might not see that often or spoken about, as media pick up bits and pieces of it now and again. And there's all kinds of bits here that I, of course, can't really get into because there just wouldn't be time for it. But I think there's a general benefit here to how we might think about doing some of this work in the future. I began by speaking about the ways that these times can definitely be described in terms of all we have lost, the harms that continue, and the devastating contexts of systemic, historical, and contemporary inequities. I could probably give another entire talk on the systemically racist practices of undervalued labor of Black and other racialized health and community leaders and community members, the erasure of their contributions, and the systematic ignoring of their ideas. I'll leave all of that for another time to get into more detail. What I hope for today is for folks to also see just that, hope. It would be easy to think about this work in oversimplified terms. That this work was about collecting race-based data or separate services or issues of representation. I believe that kind of analysis undermines the work. I think some of the conversations we have about data collection are not do it or don't do it, but how it's done. Thinking beyond data collection to the ethics and relations of knowledge, how knowledge is produced and disseminated, who it belongs to, and what is it for. Is it on us or about us or with us and for us? How do we think, beyond representation and the politics of representation, representation of bodies or not? That can be the argument, but it doesn't have to be. We are and have been saying more than that. We're thinking about who gets to speak and what gets to be said, who has influence on decisions that are made, and who is held up as a symbol of equity or diversity or inclusion, but then excluded from the structures and systems that impact how we think about what needs to be different. I think, some of the work that was advocating for prioritization wasn't thinking initially about having a separate system or separate clinic. And the conversations about separate or same can be also more nuanced by some of this work. And it begins by talking about people who know what they're doing and that serve marginalized and equity-seeking groups and have been doing it for a long time. They can tell you that what needs to be done is something that impacts and addresses what is being lived out in the world. And these conversations have really shaped, how I think about how some of this knowledge lands on the ground, how we think about structures and social relations, our analyses of systems and solidarities, and how we can do better to listen to those who do the work well. It means something when people feel like they're being listened to and responded to, and then have some control over what's being done. I think, there's a lot to learn from this, a lot to appreciate from this, but it's the kind of story that we don't tell often enough. The ways that community advocates take on some of this work here, and some of the ways Black and other racialized leaders make it happen, even through antagonism, sometimes resistance. I know I said a lot there. I described some history myself and some of the work of the clinic. I do want to leave quite a bit of time for questions and discussion, but I'll stop there.